Assalamu alaikum. Good afternoon, everyone. So this activity is a collaboration between the Ministry of Health and Saudi Society of Clinical Pharmacy. It's an honor to be here today addressing the issue of dyslipidemia, a condition that has become increasingly prevalent, not only in Saudi Arabia, but worldwide. In Saudi Arabia, the prevalence of Saudi Arabia has been on the rise for several years now, with the recent study indicated that as many as 40% of adults in the country may be affected with this condition. This is a concerning trend, as dyslipidemia is one of the leading risk factors for heart disease, which is leading cause of death in Saudi Arabia. This conference serves as an excellent platform to share knowledge, insight, and best practices related to prevention, diagnosis, and treatment of dyslipidemia. We have our eminent speakers to share their experience and expertise on various aspects of dyslipidemia management. We wouldn't be here today if we didn't have the support of our deputyship of therapeutic affairs, represented by Prof. Al-Jedai, and our medical leads, Dr. Al-Harbi and Dr. Adil Tash. And we acknowledge the partnership of Amgen, Sanofi, Novartis, and Amrit. So without further ado, let us begin the conference with our first topic in value-based healthcare with Prof. Al-Jedai, addressing the familiar hyperlipidemia, bridge of the gap between traditional and innovative innovation in Saudi Ministry of Health, vision of value-based healthcare. Dr. Al-Jedai, platform.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. Thank you very much. I would like to thank everybody who has been working diligently on making this event a reality. Special thanks to Dr. Hajar Mdahim, our speakers who we brought them during their weekend to give us an overall insights on the importance of this topic to the community and to the society, and to the achievement of one of the goals of the Vision 2030, of achieving an average life expectancy for Saudis of 80 years. I want to start with my talk. This is the disclosure. I don't have anything to disclose related to this topic, and I will not be discussing any off-label use of medications. Okay, so for those who are not familiar with our Vision 2030, let me just really do a quick recap on three more important pillars of our Vision 2030. These pillars are first, thriving economy, and it involves diversifying the economy, relying less on oil-based revenues and generating revenues from non-oil based, also improving the private sector participation in the country's economy from 40 to 65%. We have seen the recent announcement of the midway achievement of Vision 2030. And thank God we have achieved some of the goals of Vision 2030. Some of them we surpassed the goals. And the rest is coming, inshallah, before the end of 2030. This is very assuring that we are on the right path. The other pillar is what we call ambitious nation, and it involves creating highly efficient and transparent, accountable government. And this involves raising the non-profit participation of the GDP to 5%, and also increasing the household savings up to 10%. But also it involves the volunteering campaign of rallying more than 1 million volunteers per year until 2030. The last one, and this is, I want to stop here a little bit because it involves, it actually is the base for our healthcare transformation. It's called Vibrant Society. And to create vibrant society with strong roots, this involves raising the position of Saudi Arabia in the social capital index, and also having Saudi Arabia or Saudi citizens recognized as one of the top 100 cities to live in the world, and most importantly, increasing the average life expectancy of Saudi population to 80. Currently, we're hovering around 70. Well, not currently. When we started, actually, we were about 74 something, 75 between males and females. The recent mid report of Vision 2030, we're about 76.8, and this is very assuring. Our target, with the help of everybody, including citizens, residents of Saudi Arabia, policymakers, healthcare providers, and industry, is to reach our 80 years target, inshallah. Why I stopped here? Because this is where the 3 transformational goals for our national transformation plan or program conforms with. These are the enablers of Vision 2030 in terms of the health. And this is where we started building our healthcare transformation plan, focusing on 3 aspects. Number 1, improving health. Second, improving healthcare, and these are 2 different things, by the way. And third, improving the value. And when we say improving health, we mean improving the health of the overall society so that they don't get sick and need to be treated by our healthcare system. But also we would like to improve the healthcare system itself. And the way we would like to improve healthcare system is by improving the quality of care, improving the access to care, and finally, making it an equitable, timely, and patient-centered healthcare system. Lastly, we would like to achieve all of the above by improving value. And when we say improving value, we do not mean necessarily reducing cost. We mean improving the value of whatever we provide to our patients and to our society in order to improve their health. In other words, it means that we could spend more on healthcare, we could spend more on health technologies, including devices, medications, procedures, and others. We could actually spend more on population health, including preventive strategies, but the ultimate outcome is actually worth every riyal that we spend. Okay, so why do we need to do the overall healthcare transformation apart from improving the quality of care, improving the access to care, and making it equitable and patient-centered? The issue here is actually multifactorial. Here in Saudi Arabia, similar to other developed countries, we have issue with increasing chronic diseases prevalence. We have done excellent job in terms of eradicating communicable diseases in the past. So let me shock you with some numbers. In 1962, the average life expectancy of Saudis was 46 years. Can you believe this? 46 years, only 1962. And by working on mass vaccination programs, especially for kids, and making it mandatory programs, also by eradicating communicable diseases like brucellosis, malaria, TB, and many others, we were able to improve our average life expectancy to 60 in the 80s, end of the 80s. And now we're talking about 76.8 or 77, but improving further the average life expectancy requires paying more attention to non-communicable diseases, because currently what we are worried about is the non-communicable diseases, including but not limited to diabetes, dyslipidemia, cancer, cardiovascular diseases, and many other. Now, with the increased prevalence of these communicable diseases because of lifestyle issues, because of increased prevalence of obesity, that is a comorbidity with most of these non-communicable diseases, and because having multiple comorbidities actually results in what we call premature death. The other factor that we have here is the increasing population. In the 80s, we were 20 million. Currently, we're about 35 million. It's expected that we hit the 50 million between 2070 to 2100. That means we're going to have more population to take care of. Let me also give you a quick information. It's not only the population of Saudi Arabia that we have to take care of. It's the fact that we are aiming within 2030 vision to have 100 million, what we call religious tourists per year. And this means that we are expecting to have about 5 million Hajj, 5 million population during Hajj, and around 95 million performers of Umrah per year. All of those people need to be taken care of. This puts a lot of pressure on the resources, especially healthcare resources. So Saudi Arabia is in a different position than any other company, than any other country in terms of not only taking care of their population, residents and nationals, but also visitors of the two holy places. The other thing with the increasing population, we are a young society. So the percentage of people who are less than 30 years are about 65 to 70% of the whole population. But at the same time, we are having more and more increase in the prevalence of elderly. It's expected by 2030, the percentage of elderly population is going to increase from 4% before the beginning of 2030 plan or vision to 11%. So the whole population will increase. We'll continue to be a young nation, but we will have the sector of elderly patients increasing from 4 to 11%. This would require that we pay more attention to chronic diseases in order to achieve this target. The other issue we have is the increased cost of treatment. Nowadays, we do not treat diabetes with sulfonylureas, which are cheap and not effective, and they do not have the value from is the constrained healthcare budget. There is no healthcare system that could sustain the ever-increasing cost of newer treatments and newer agents. So it's very important to be able to introduce health technologies, including newer medications, based on the value that they bring with it. Because you do not have unlimited budget. And ultimately, you will have to prioritize between treating common prevalent diseases with agents that reduce the overall morbidity in those population compared to treating very few patients with rare diseases with almost the same budget. So it's a very difficult decision for health policymakers and payers. It involves not only medical opinion, but societal, humanitarian, as well as ethical and moral aspects. Okay, so this is where the population is, if you can see, I don't know if you can see, sorry. I don't know if you can see this line. The mauve line, okay. I don't have a pointer. Unfortunately, this is not a pointer. But if you see the purple line that is going, starting low, this is the patient's age or the population age of 65. By 2050, look at the percentage. It's going to be around 14%. This means that we will have to cater for common non-communicable diseases that affect the elderly more compared to now. So we're going to have to treat more diabetics, we're going to have to treat more hypertensive patients, more cardiovascular patients, because these usually also are more common in the elderly. Okay, now the newer launches of these agents, market growth drivers, in terms of the volume growth, the pharma market, the price growth as well. But overall spending on pharmaceuticals is actually increasing, despite the fact that we haven't seen an increase over the past few years, a similar increase in the medications budget, for example, for Ministry of Health. The last thing I would like to pinpoint here is the fact that it involves multiple disease states, ranging from endocrinology to cardiology to oncology and other immunology, rheumatology, dermatology, and others. You know, in the past, we used to treat most dermatological, immune-related dermatological diseases with steroids, topical or oral, 30 years ago. Now we treat them with newer biological agents, immune modulatory agents that come with a hefty price. Okay. The issue here is that this continues because it's sustainable. We cannot continue to spend more money on these medications or these health technologies without evaluating their value in terms of the overall health care that we provide to our patients. As you can see, we are expecting to have much more expensive type of medications in the next few years. We're talking now about cell and gene therapy. So we have RNA therapy, we have cell therapy, and we have gene therapy. So we could be treating heterozygous familial hypercholesterolemia, for example, or homozygous with gene therapy in the next 5 years. And this is going to come with a very heavy price tag compared to what we are doing now. The other thing is, this does not only involve oncology patients, which is mostly this is what we are treating with currently. Cell therapy is mainly approved in oncology, but gene therapy is actually expanding. Currently, we have about 8 approved gene therapies worldwide. We're expecting in the next 4 to 5 years to reach about 100 gene therapies approved to be treated to be used in multiple disease areas. RNA therapy, not only involving vaccines, but also other disease states, including neurology, metabolic diseases, ophthalmology, and infectious disease. So what's the roadmap to our healthcare system or value-based healthcare system? It's very important to look at if this is a cost-effective introduction and whether it's going to bring with it potential cost savings on the overall healthcare budget. The other thing, it's very important to evaluate the safety, efficacy, and the quality of these agents. It's very important that the introduction of such a new treatment brings with it a new quality of treatment. And when we say new quality of treatment, we're not only talking about the efficacy. We're not only talking about better safety or better efficacy, but we're talking about other aspects like patient experience, like quality of life. And with this brings us to our discussion today, dyslipidemia. This is how we worked on the dyslipidemia project in Ministry of Health. The first thing we did, and thanks to our champions, our specialty leads, Dr. Mohammed Al-Harbi, Dr. Adil Tash, who really worked with us across not only dyslipidemia, but many other disease states involving their specialties. The first thing we did actually is develop national guidelines that could standardize the practice of managing dyslipidemia in its overall term, including familial hypercholesterolemia, whether it's heterozygous or homozygous. They were detailed enough to guide the clinicians and also allow the referral to specialists in this field. So the second thing we did is we ran budget impact models to see if the introduction of newer agents, for example, PCSK9 inhibitors, would be a valuable addition to our formulary. Not only this, but we also we expanded our budget impact to include other agents for treatment of homozygous familial hypercholesterolemia, for example. And we are currently expanding this budget impact to evaluate the introduction of newer agents for dyslipidemia that were not evaluated in the past because they were not approved at that time. So after this, first we developed the guidelines, we conducted our economic evaluation, and then we developed what we called the familial hypercholesterolemia electronic registry. And this is state-of-the-art electronic registry that captures almost all aspects of patient journey, starting from patient demographics, patient history, the diagnosis, how their familial hypercholesterolemia is managed, and whether they are developing any side effects or adverse drug reactions, and how effective this was. Not only this, we coupled this with an extensive monitoring plan that guides the decision of continuation of therapy versus discontinuation, escalation versus de-escalation. Also, we involved our payers as well as providers and health policy decision makers in this process through establishing a scientific committee that evaluates every single patient before, during, and after reaching the targets, including the monitoring plan. So what's next? You know, one of the things that we also worked on, so again, I would like to remind you, developed the guidelines, then we did our economic evaluation, and then we did our registry, electronic registry, but then we coupled all of this with what we called value-based agreements that focus on the value that these medications will bring, and coupling the outcomes from these managements or from these diseases with the reimbursement or the payment to the company. So one of the things that we implemented recently, actually several years ago, is the PCSK9 inhibitor in Ministry of Health, where we linked the payment to after getting free treatment initiation period and getting the financial-based reduction in cost, we added the outcome-based agreement through evaluating LDL reduction every 3 months to see if the patient, according to our guidelines and according to the expected reduction of LDL with the introduction of PCSK9, and then if we reach a certain LDL cutoff according to what we agreed on as clinical criteria, then we pay full 100% of the whole cost of the medication. But if we get between certain levels, let's say 40 to 50% reduction in LDL, then we only pay 75%. Between 30 to 40% reduction, we pay 50%. Anything less than 30%, we do not pay, okay? So this is just an example of coupling or linking the outcome to the payment. Not only this, it wasn't only a surrogate marker of LDL that we linked to the payment, but we also linked it with the development of MACE. So any cardiovascular complications while the patient on PCSK9, any patient who develop these, then we get reimbursement of the last 6 months. This means for us failure of the patient. One of the things that we worked on a national level is developing what we call the utility valuation set for Saudi Arabia for the first time ever. And this is going to be very important for us in the future to evaluate the cost utility studies and also improve our economic evaluations in the future. This has been a very large project that took about 3 years with the help of multiple stakeholders, and we were able to finish it before the end of 2022, and we are in the process of publishing this work. Hopefully we'll see it in the next few months. We also published for the first time the cost effectiveness threshold for Saudi Arabia. And this is very important to evaluate whether any medication is cost effective based on the cost effectiveness threshold that we have for the first time in Saudi Arabia. Last thing, and I will stop here, the introduction of population health management program. And it's very important that this program is implemented on a population level because it improves the quality and outcomes and hopefully lower the cost of individuals. The program's objectives is to improve the quality of care of patients with familial hypercholesterolemia and provide state-of-the-art integrated multidimensional program tackling the journey of patients from the time before they become dyslipidemic until they are diagnosed. And this involves early diagnosis, stratification of population by certain characteristics, surveillance and monitoring, financing and value-based payments, and finally, primary prevention. We also coupled this with introduction of clinical pathways, and we have our specialty lead leading this to introduce clinical pathways in our electronic health records so that we standardize the care of all patients across all of our healthcare facilities. And we aim to align these clinical practice guidelines with the day-to-day practice of our individuals or our providers, especially those who are non-specialists. We don't worry about, cardiologists, endocrinologists in managing dyslipidemia, even, without the involvement of clinical pathways and electronic health records, but we worry about others. Our GPs, for example, our internal medicine colleagues, our family medicine colleagues. So it's very important for us to make sure that they are all aligned, whether they are taking care of the patient in the outpatient settings or in the inpatient settings. Finally, we are working on exploring innovative funding programs, including multiple systems. One of them is called subscription system, like the Netflix-based model. We have the bundled payment and the pooled funding, other risk-sharing funding programs. And we would like to have this at the level of the accountable care organization that we will be creating, or that we have been creating and continue to create until 2030, in order to make sure that they have what we call a value-based programs. This is very important to transition from the fee-for-service system into more of the rewarded, value-based healthcare system, and ultimately improve the quality of care with the improvement of the value. The clinical trials is very important as part of the innovative funding programs, and with the introduction of Saudi National NIH, we hope that this will be taken, will be addressed in order to make sure that we increase the number of clinical trials that are conducted here in Saudi Arabia as part of the multi-center trials, but also initiating clinical trials from Saudi Arabia on a national level. And an example, UK, for example, they generated a revenue of £8 billion of gross value added to their economy over the period of 2016 to 2018, only from working on a clinical trial program. They also, this resulted in cost savings of £355 million and created also job opportunities. So this is also in alignment of our Vision 2030 of diversifying our economy and generating revenues from non-oil based. I promise this is the last thing. Considering the level of innovation and feasibility, we are looking for more innovative funding models currently, and we're exploring these different models. Some of them would fit our system here in Saudi Arabia in terms of payment structure, the laws and regulations in Saudi Arabia, and some of them will not. We were able to introduce for the first time in Saudi Arabia innovative payment mechanisms. Now we hope that we will be able to introduce for the first time innovative funding. With this, I end my talk. Thank you very much, and sorry for the delay.